Welcome to the Health Wealth Podcast and Radio Show with Forbes author and contributor Dr. Josh Luke, America's Healthcare Affordability Authority. Visit drjoshluke.com for information on speaking appearances and other resources.
Just a quick disclaimer that we had some video and Wi-Fi complications during this taping, so you may not see one or both of us during this interview on the screen, but rest assured the audio all sounds good. Thanks again for tuning in. Dr. Josh Luke here with the Health Wealth Podcast and Radio Show. It's my honor today to have a former Obama administration staffer with us. It's Anton Gunn. Anton, welcome to the show.
Happy to be with you. Thanks for having me, Dr. Josh Luke.
Yeah, and so tell us a little bit about where you're from, where you went to school, and how you ended up as part of President Obama's staff. That's awesome.
Yeah, so the long story short is that I'm a native of Hampton Roads, Virginia. I'm a military brat, come from 4 generations of military men in my family, and they all put on a uniform, but I didn't put on a military uniform. I put on a football uniform, and I see you're wearing the USC Trojans on your shirt there.
Here it comes.
I went to the real USC.
Okay.
University of South Carolina.
So did you play for the old ball coach?
I did not play for the old ball coach. About 20 years before he got to the school. But I played offensive line at the University of South Carolina, and I finished up in 1994. And when I finished up, my first career opportunity landed me working at a local nonprofit, and my boss handed me a clipboard and says, I need you to go out and help us to assess the health of this community. And I said, what do you mean assess the health? She says, well, you need to go talk to people about how they access the healthcare system.
Wow.
And so at 3 years old, I was going door to door in communities, going to neighborhood meetings and talking to residents, and I would ask them the following questions. Question number 1, do you have health insurance coverage? In 75% of the communities that I was in, the answer was no. And then my second question was, do your children have health insurance coverage? And 50% of the time, the answer was no. So then I said, well, if you don't have health coverage and your children don't have health coverage, what happens to you when you get sick? What do you do? And that began this journey of mine of collecting stories from real citizens in communities who struggled accessing healthcare in their communities. And I learned that hospitals, there are 2 types in every community. And when I mean 2 types, you might have 5 hospitals, but they all fall in 2 categories. And hospital number 1 is when something happens to you or someone that you care about, someone that you love. That's exactly where you want to be because you know you're going to get good care. They're going to take care of you and get you back home to your family. And then there's a second kind of hospital, the hospital that you don't want to go to because that's where you believe people go to die. And it didn't matter which community you were in. Some people loved the hospital and had great experiences, and other people had bad experiences. And then that turned into a dialogue with those leaders in those hospitals about what they were doing to improve the broader health of the community, or as we talk about in the Obama administration, the triple aim theory. How do we focus on population health, the quality of care that people receive, and how do we lower the cost of health care by preventing disease and making sure people are healthy in community? Next thing I know, Josh, I was spending a decade-long career working on every aspect of healthcare, from Medicare Part D rollout to insurance regulations to how hospitals got to expand. So certificates of need, I was all in on prescription drug pricing, you name it, I had done it in the next decade. And that led me to a place where I felt like we didn't have enough leaders in public office who understood the complexity of the healthcare system. So I made a decision to run for public office. And I ran for the state legislature. And in 2008, I got elected to the House of Representatives, and I served on the Medical Affairs Committee, Children's Affairs and Social Services. And so I got a chance from a regulatory framework and from a policy framework to look at where the healthcare system was broken, how the waste was being generated, and how we were having inefficiencies, and how we deliver care and improve health outcomes. And after 2 years, 1 term in office, the Affordable Care Act passed on March 23rd, 2010, and I got a phone call from a former South Carolina colleague who was working in the Obama administration as a White House liaison, and he asked me, would I be interested in serving my country working for the President of the United States at the U.S. Department of Health and Human Services? And coming from a family who's had a long tradition of service, putting on a uniform, I never put on a uniform, but I felt like this was my obligation as a member of my community to serve. And so I got appointed to the regional office at HHS, the regional director's office based in Atlanta. If you know anything about HHS, it's the Health and Human Services Agency that manages all the health and medical needs for our nation. And Region 4 in Atlanta is the largest region. It's 8 states, 62 million people, about $128 billion of the federal footprint in that region. And there were so many challenges in that region.
Plenty of challenges in that region for sure, yeah.
So I was there 19 months and was the most senior official from the appointed official in the Obama administration over health and human services. I worked with hospital CEOs and nurse managers and leaders, really helping them to understand how the Affordable Care Act can improve outcomes for patients, lower costs, and also improve the overall health of the community. That was my job.
Wow.
And then I got promoted. And I got promoted to Washington, D.C., into the Office of Secretary of Sebelius, where I became her Director of External Affairs. And I managed all of her relationships with every external entity. So whether it was big business or small business, hospitals, constituency groups, drug companies, healthcare companies, even the smallest women organizations in communities who cared about women's health, I was the conduit of how the Secretary's office interfaced with these groups. And after about 6 months, when it came time to roll out the Affordable Care Act, I moved into a role where I worked in the White House with the team who was developing a strategy on how we were going to get 7 million people enrolled in coverage and make sure that it would be lower cost. And so I ended up in a senior role, kind of advising the president and the secretary on their strategy to roll out the Affordable Care Act so Main Street could understand it and take advantage of it. And that's how I got.
That's a cool story, man. I had no idea. There's a couple things you said in there that probably you didn't know about me that will obviously are some of the reasons that that you and I get along. But I was actually the CEO of several safety net hospitals.
Yes.
And it's interesting that Anton's probably the first person I've ever heard outside of myself say this, because people don't like to acknowledge it. There's the hospitals that you go to by choice, and then there's the hospitals that I ran. And
Yeah.
believe it or not, in my almost 10 years as a hospital CEO over 3 safety net hospitals, I would say this exact quote in orientation to new employees. I would say, guys, this is a hospital that most people don't come to by choice.
Yes.
So let's be good. In fact, let's be great at what we are doing and not worry about what we're not. Let's serve the neediest of the needy. Let's make sure we're meeting their needs and not worry about the fact that America has a hospital crisis because there's the haves and the have-nots. That problem's not going to be solved in the near future, and our little safety net hospital is certainly not going to solve it. I have an interesting question I want to ask you about dish hospitals and private dish hospitals in a minute, but I don't want to jump to that yet. I want to talk about, by the way, when you were working in the eastern Atlanta region, was Dr. Richard Wild the medical director there? Because he's a great guy. I had a lot of conversations with him.
Yes. So Dr. Rick Weil was definitely the CMO at CMS there. He and I actually did a few events together where we literally traveled in Florida and a few other places.
Yeah.
Presentations to different audiences about the Affordable Care Act, about CMS's obligations and what they were doing to focus on innovation in the system and delivery system reform. And we talked a lot about the challenges inside of the healthcare system, inside of organizations. And so Rick is a fantastic guy, probably one of the funniest guys that I've ever had the chance to engage with. He has an incredible life story, not only as an MD, but also a lawyer. Most people don't even know that he's a lawyer.
So you served in the Obama administration, and then did you serve right up until President Trump was elected, or were you already gone by then?
Yeah, I was gone. I left in January of 2014 is when I left the Obama administration.
And tell us why you left. Where'd you go? Because I know since then you've been a leadership coach, and you have the you're a presidential leadership specialist. You're part of the Aspen Institute, a Liberty Fellow, a huge honor. But tell us what drove the departure, and what was your kind of first gig after that, if you will.
Yeah. So the long and short of it, what drove the departure is the same thing that drives every presidential appointee to leave. It's exhaustion and burnout. And your family. Sometimes it's your family that I served the president faithfully for 41 months. The average presidential appointee only makes it about 18 months before they leave. And so I did double duty, if you will, and got kind of burned out. Wanted to spend more time with my family, which was really an important priority. So I started my own kind of a consulting practice, my leadership practice, if you will, because one of the things that I'll say about whether it's Obamacare or Trump care, all of these things are important impacts on our healthcare system. But the biggest impact, in my opinion, are leaders who don't care and don't understand what's happening to their people. And so I made an intentional investment to focus on developing leaders and helping leaders to make better decisions inside of organizations. Because fundamentally, I believe this is that everyone wants to be great. And our healthcare system has done some amazing things across the board. But the biggest challenge in healthcare right now are nurses are quitting their professional practice after about 3 years. Physicians are going into healthcare, practicing a decade, and then transitioning out to something else. That the people who are charged with taking care of the most people are the ones who are having the most stress and the most burnout in an organization. So you as a leader in any organization, you got to think about turnover. What does it cost you when you don't have people who are not feeling good about what they're doing? And I think we change that dynamic when we start to focus on how leaders make decisions, how they build their teams, how they engage those teams more deeply, teach them how to act with conviction so that we all can have a lasting impact on the lives we touch. And that's literally what I've been doing since I left the Obama administration, is sharing my experiences. So as I mentioned, working for President Obama, what I didn't mention is that I have personal life experience with 3 other American presidents. So Bush 41, Clinton 42, and Bush 43. Through my life experience, I've had the opportunity to engage with them at a personal level with as a president and their administrations. And so I talk about what I learned from each president in those interactions and what applicable things can you learn as a CEO, as a business manager, as an executive to lead like the president has led, to have a lasting impact on the people that you serve, the way they've all had a lasting impact on our country. And so I kind of synthesize this down in simple, bite-sized, practical things that leaders can do on a daily basis that will engage them more deeply with their teams, to have a lasting impact, and to really make a difference in every life that they touch.
That's fantastic. So one of the things that I'd love to ask you about, Anton, is, and I think in this politically charged environment right now, there's not enough people who are willing to acknowledge, hey, that worked, but man, if I had it to do over again, I would probably change A and B. And from a Affordable Care Act perspective, you mentioned you weren't appointed until afterwards, but when you look back at the ACA, which was a massive shift from the fee-for-service, what I call the fee-for-service free-for-all, with no checks and balances, you find a doctor who'll write an order and everybody gets paid and everybody got rich, and that's really why people didn't want to transform, because it's capitalistic society and the people in charge were all making a lot of money lining their pockets. Problem is, the average American couldn't afford health care. And they still can't. So Anton, one of the questions I want to ask you, and I know you weren't appointed until after the ACA was passed, but you worked so closely with President Obama, Secretary Sebelius. You learned so much, and there had to be moments where, that we're not exposed to, where they say, man, I wish we would have just tweaked this or that on the way in. And one of the things that's disappointing about this politically charged environment right now is people aren't so willing to go on the record and say, man, we were real close, but we just missed on A or B. And there's only been, the exchanges and maybe one other thing about the ACA in itself that just didn't work as planned. But if you had to go back to 2009 or 10 and were asked input on, hey, how to take this value-based care program they put together and tweak it slightly, what 2 areas would you focus on?
Yeah, so I'll tell you this, after having 20 years of working on healthcare reform, starting in 1996 all the way up until administration and beyond, is that there were a lot of, the ACA was not anything new. That's the thing that I wish most people understood. We acted like this was a brand new piece of public policy, doing things that had never been tried or even talked about in healthcare. And what it was 20 years of tweaks and changes that happened on a state level or happened on a local level, put together in one piece of public policy. And the framework was good, but there were some things in which got compromised because of the political environment. Sure. So you were the entire dialogue about do we need to have a public option for people? You remember the whole conversation about public option.
Sure.
Well, public option is really about saying for those who cannot afford it, who are lower income, whose costs continue to rise, is there something for them to buy into at a base level that would give them basic coverage that meets their needs? And if you want all the other bells and whistles, you can buy that supplementally on your own.
Mm-hmm.
The public should have been a part of the process, but it was jettisoned very early on in an effect to try to get the compromise. The second piece, and I think you probably would contend with this, is that what we did not do around prescription drug coverage. We all know prescription drugs still drives a lot of cost for the average consumer. You know, you think about 55 million people suffer from diabetes in the United States of America. We want to get them healthy and get them physically active, but a lot of them are on insulin or other drugs that relate to that. But the average diabetic drug for like Trulicity or some other one costs a patient $800 a month. That's not sustainable to maintain any level of your health. So we should have done more around prescription drugs.
Let me just wrap up with a couple more questions, if that's okay, Anton. So tell us a little bit more about what you're doing now. You got into a little bit about you being a presidential leadership specialist and your experience with 4 presidents, not just one. But tell us a little bit about what you do nowadays, what people can learn from you.
Yeah, so basically what you can learn from me is that I work with organizations that want to deliver better care, better value, and better outcomes for the patients that they serve and the care team members that take care of those patients.
So you're a consultant for hospitals and
yes,
healthcare?
Yes.
Okay.
So I work with hospitals, healthcare organizations. I even work with some insurance companies who, again, are a part of the healthcare continuum, and they do quality-based work when they're focused on their relationship with their providers. We got to do a better job of making sure that the leaders in healthcare understand our challenges. So whether you love Trump care or hate Obamacare or hate Trump care and love Obamacare, it doesn't matter. What the most important thing is that we need people who operate inside of healthcare who do care about the patients that they serve, the costs related to the administering that care, and how do we improve health in our communities. And so for the average business owner, I mean, they're facing the external end of this. They just know that their insurance costs keep going up 20% every year, but their employees are not getting 20% healthier every year. So they're paying more and more, and they're getting less and less. And so the most important thing that we have to understand is that we're 20 years into a 40-year transition of our healthcare system in America, and there's a lot more disruption to come. So the talk between Amazon and Berkshire Hathaway and JP Morgan Chase has the opportunity to at least yield a conversation around how we move to the next level in transforming our healthcare system, and how do we create this environment that does lower costs for the average individual family and for the business owner who's trying to provide a good or service and know that their people is the most important part of that organization, and 80% of their people P&L statement is their healthcare costs, and every business owner wants that to be smaller. And I think we can do that by focusing in on how we understand what's happening, how do we make sure consumers are informed and make better decisions, and those leaders who lead in healthcare are able to help those consumers make better decisions.
So Anton, I have a theory I've always had since the ACA passed, because I was always a proponent of value-based care, but I also ran safety net hospitals like we talked about earlier, where people didn't really go to by choice. And in my case, it was largely immigrants here in Southern California, city of Anaheim. And I've often told a story and written this story and shared it with folks. And it tends to get a politically charged reaction, although that's not the intention, which is, hey, the folks that were coming to my hospital that couldn't afford to pay for the emergency department knew that EMTALA permitted them to come to the emergency department for free. So had I gone into the cafeteria and patted him on the shoulder and say, hey, buddy, good news, for $400 a month, you're going to get your whole family covered after the ACA, he would have said, I'm not interested. And so, and there was no doubt, that wasn't even a debatable, because the immigrants understood that EMTALA, the Emergency Medical Treatment Active Labor Act of 1986, made care free in the emergency department, that they didn't need insurance. How did that play into the discussions about the mandate, and where do you see the future of the mandate? Because it seems that the one thing the Trump administration's, the two things they're going to do is go after taxes and end the mandate. So So, combining all of those thoughts, what are your thoughts on the future of the mandate? And does every American want healthcare access to it?
Yeah, well, I mean, I think the context for me is whether people want it or not, they will use the healthcare system at some point in time. And if we don't have any kind of framework of making sure that people use the healthcare system in the right way, and there's some way to cover the cost of that, it becomes an untenable and unsustainable framework. And so I do understand, your experience as a healthcare leader and administrator in which you saw people come in and they knew the emergency room was a way to go. But we also know that the emergency room is the most expensive place to deliver healthcare, and
By far, yeah.
should not enter the emergency room. So some of this is a culture shift and a culture change, how we talk about our health and how do we educate people about how to use healthcare services and when to use them, and also making them more accessible outside of the emergency room. So what do we focus on primary care, and where do we offer care settings? And some employers are even putting clinics inside of their plants and facilities because they know it's a much better way for them to get their employees healthier and not lose their time away from work. These are all parts of the solution to the problem. And I really do believe that when the private sector, when the large employer or that employer who is spending a significant amount of their healthcare costs takes ownership to understand what their levers are in the system, is when we'll get the greatest disruption. But I don't think that mandates around EMTALA will ever go away, because there's a lot of bad things that happen when people can't get care. But we have to change the culture of how people understand what the healthcare system is and how they access it. And the persons who have the most important role in doing that are the people who work in healthcare, because you and I can be as great of experts as we want on the Affordable Care Act, on the ACA, but I know plenty of patients who went into their doctor's office and said, "Hey, doc, what do you think about this Obamacare stuff?" And if that answer wasn't positive, if that answer didn't provide them information on how they could access the system in the right way or improve their health outcomes or have continuity of care, then that patient made a decision because they believe that their physician or their medical leader is a better expert than you are or than I am or anybody in Washington, D.C. And so in that regard, those leaders have a awesome responsibility to be able to make sure that they educate and help create an environment where people understand how to utilize the system. However, doctors are not trained that way. In medical school, you don't take any courses on health insurance coverage. You don't even take any courses on nutrition in most med schools.
What is your favorite sports team to cheer for, whether college or pro?
Of course, my college team is the University of South Carolina Gamecocks, who play in the Southeastern Conference, the best football conference on the planet Earth. And so I enjoy my Saturdays in Columbia, South Carolina at Williams-Brice Stadium cheering for my team. But basketball, I'm a Pistons fan. Goes back to the 90s of the bad boy era of basketball, and so I became a Pistons fan. So those are the sports teams that I'll cheer for, and I spend a lot of time watching them play and enjoying their games.
Well, I'm a LA Showtime Lakers fan, so we'll have plenty to talk about next time we cross paths. So it's been my honor and pleasure to have Anton Gunn, former Obama administration staffer, on the show.
Thanks for tuning in to this episode of the Health Wealth Podcast and Radio Show with Forbes author and contributor Dr. Josh Luke, America's Healthcare Affordability Authority. Visit drjoshluke.com for information on speaking appearances and other resources.